Welcome to This Week in South Carolina. I'm Gavin Jackson. Access, quality, and cost. Those are all issues related to healthcare, especially in a rural state like South Carolina. One program that is addressing this issue is telehealth, which allows providers to care for more patients in more places.
Yeah, I'm just moving the camera around.
Telehealth is just another way for a doctor or a provider to deliver care to a patient. The traditional way is face-to-face, where you go in and you see your provider and you're in the same room. But telehealth allows you to connect with your provider and not be in the same room.
Well, that's good.
So the nice thing about it is with the technology that we use, the patient can be in a school, the patient can be in his or her home, the patient can be in the primary doctor's office or a clinic and connect to a specialist. The goal of telehealth is to make sure that every person in South Carolina has access to quality health care, regardless of their community type.
Joining us on what is known as Telehealth Awareness Week across the state of South Carolina are the co-chairs of the South Carolina Telehealth Alliance, Dr. James McElligott, Medical Director for the Telehealth and Medical University of South Carolina, and Kathy Schwarting, CEO of Palmetto Care Connections. Thank you two for joining us.
Thank you for having us.
You guys both came up, traveled very far, and we have a lot going on. But Kathy, I want to talk to you first about just the widespread use of telehealth and just where we've come from just several years ago and just how widespread telehealth is right now in South Carolina.
So I became involved in telehealth back in 2010 as our local hospital was closing, and I had spent a lot of time in physician recruitment. And it dawned on me with telehealth becoming so prevalent that was going to be one of the only ways that rural and underserved communities were going to have better access to care. Bringing physicians into a rural community, that doesn't exist very often. So telehealth has grown tremendously over the last 8 or 9 years. A lot of that has been because MUSC has spread it throughout the state, and Department of Mental Health, which is one of our biggest telehealth providers, they have been doing this since maybe around 2007, I think. So there has been widespread use in emergency rooms. We have seen an abundance of school-based telehealth. Now it is really not acceptable for a child not to receive care in a timely manner. I had a nurse call me the other day, and she had a child that was sick for 3 days. And for whatever reason, parents were out of town working. She could not get in touch with the parents. The child had not seen the doctor. So via telehealth, that child can be seen and prescribed the medications that they need. So school-based is a great way to implement telehealth. It's in emergency rooms like telepsychiatry. It's in rural physician practices where you can now do a telepsychiatry or telemental visit in your local provider's office and eliminate the 2-hour transportation time, because folks in rural areas don't have transportation. We don't have transportation systems. We don't have Uber, Lyft. Paying somebody to take you 2 hours is a very expensive thing to do. So it really is widespread, and from specialty care to primary care. In some instances, communities do not have access to primary care. So.
Yeah, and when we talk about this and also emergency care, when we look at 4 hospitals that have closed in South Carolina, places like Bamberg, Winsboro, Bennettsville, and Barnwell, that makes those areas, like a lot of rural areas in South Carolina, relying on expensive helicopter trips and urgent care centers. So does that make these populations more vulnerable, or is that where you're saying telehealth is really filling that void essentially in South Carolina? I mean, are these populations secure in a sense with healthcare access with telehealth at this point?
No, I would not say that they are. I mean, when you live in a community and you lose your emergency room, you have things to worry about out in the rural areas, like if you are bitten by a snake. I mean, time is of the essence when that happens. And so when you don't have a hospital, you don't have an emergency room, it changes. It's a game changer in those rural communities. And so I think that, for example, MUSC has a new relationship with Hampton Regional Medical Center, which is a small 34-bed hospital in Varnville, South Carolina. And they are really infusing telehealth as a way to bring services into that community. And telehealth can be one of the reasons that rural hospitals can actually make it in today's world, I think. It brings services in that they can't afford to bring in on their own.
So it's a little worrisome just to hear that, again, losing those hospitals kind of leaves that void. But even though
it helps to fill the void. So now instead of going into the emergency room, we have a new emergency room. For example, Bamberg and Barnwell hospitals closed, both within a couple of years of each other. Now we have a new ED. What we're trying to do is to create a telehealth access center at that emergency room. So you not only go there for emergency care, but you can go there for specialty care. If you have an appointment with a nephrologist, or if you have a gastroenterologist and you can't get to Charleston, that provides you with a center and a location so that you can go get that care within your community. So telehealth is filling the gap, and it's really causing us to think differently and be more innovative in our thoughts on how you can. The traditional way of bringing care into a community has changed. Now technology has completely changed that idea. The physician doesn't have to physically be there. The technology is a lot cheaper than it used to be. It's very user-friendly, very easy to use. So it is a game changer.
And we have another segment coming up, and we'll get Dr. Jimmy in this in a minute, but we have about 2 minutes, and Kathy, I want to talk about the accessibility of telehealth in these rural communities. And when we talk about broadband, that's a big issue, connectivity on rural areas, and you need a certain amount of bandwidth to get telehealth to actually work, to do this video conferencing with a doctor. What's the status of that in South Carolina? Are we fully connected in these areas, or are these hospitals or doctors' offices able to actually have telehealth work for these people in rural areas?
We are not fully connected in South Carolina. We're a long way from that. We identified a few years ago that broadband is one of the biggest barriers in these rural communities. If you don't have internet connectivity, but you also don't have cell coverage. So with remote patient monitoring going into the home, folks doing more and more direct to consumer, which is where you're on your smartphone and you talk directly to your provider, you've got to have cell coverage, you've got to have internet capability if you're doing it from an iPad. So we've just done some mapping and really pulled data together to look at where we have the least access across the state, and I think that is going to help us. I was at a meeting earlier this week in Orangeburg County, and they just received, Jimmy and I were both there, they just received a $10 million grant to build out broadband into that rural community. So the focus is on broadband, and we are going to get there, but it's going to take all of us working together, and that is a huge area that we need to pay attention to.
So it definitely needs to be the focus,
It
and
does.
it needs to be improved because we can only do so much at this point.
That's
is what
right.
you're saying.
The technology's there. Now they have to have the ability to use it.
And really quickly, can you guys coerce telecommunications companies or force them in some ways to help expand their connectivity in those areas based on the need for healthcare coverage?
Well, we like the word partnership, so we are trying to not force them, but we are trying to entice them to be partners with us. We have now some of the legislature, some of the congressional members that are helping us in South Carolina to pull some of those service providers together. And I think there will be a lot more pressure for them to partner with rural communities to do what should have been done some time ago.
Telehealth continues to go rapidly across the country to benefit people in emergency situations. Our telehealth team at South Carolina ETV shares a story about a little girl whose life was saved by a team in different locations 100 miles away.
July 1st of last summer, our at the time 4-year-old Annie was running around, was going to run inside, ran and just slipped on the polished concrete and fell and hit her head. And it was a bad fall, but we kind of checked on her. She didn't even really cry that much. She cried, but it wasn't the worst thing you've ever heard.
We were keeping a close eye on her, but we weren't expecting anything to happen like it did.
So it was about an hour and a half after that she started to not be normal, according to her parents, and they took her to a local hospital. That hospital, when she arrived, noticed that she was not doing well at all.
I was sitting in triage and I heard a cry, and I met Kelsey holding Annie in her arms, and she basically just handed Annie to me and said, "Please just help my daughter."
One of the nurses actually carried her into me, and she was at that point barely responsive, and we went straight to the CAT scan machine.
They immediately noted that there was a very large bleed on the outside of her brain inside the skull. That type of bleed is called an epidural hematoma, and it's one of the most life-threatening types of bleeds because it can expand very quickly.
At that point, 2 phone calls went out, one to the air support and the other one to Dr. McSwain at MUSC.
We ran up to the PICU to
call into the Waccamaw Emergency Department and very quickly connected the telehealth consultation. We were able to recognize, based on changes in her vital signs, that the swelling in her brain had progressed to a point where she was at risk of progressing to brain death. They immediately jumped into action, and our team was able to be a part of that scenario and really help out as though we were all really part of the same team.
And he was able to give our doctors and our nurses direction on, medications to give and vital signs, blood pressure parameters, anything, that we needed to know. He was right there, and any questions that we had, he was there the entire time. So it was having a really nice big team all at the bedside.
We were able to get the swelling on the brain decreased enough so that she was stable for transport, then clearly communicate the situation to our pediatric neurosurgeon, and our transport team flew her here to MUSC.
That was one of the things that saved Annie's life, because we were later explained that if she had been flown there and had not been seen by the MUSC doctors, she would have had to go back through the ER, been evaluated by their team, and then gone into surgery. And at this point, the type of brain injury it was all about timing.
There was no delay. She literally came through the ambulance and went right to the operating room.
The blood was evacuated out of her brain and the swelling was relieved within 8 minutes of the time that she hit the door to MUSC.
So when they said she was going to make it, she would be alive, it was, something no parent should ever have to go through, but certainly a good feeling.
So Annie would have almost certainly died if we didn't have this program in place. She is the type of patient that we built this program for, and it was really a miraculous save and a miraculous display of teamwork.
There were millions of prayers being said for her, and I know that I couldn't breathe until we heard that she was out of surgery and that she was alive and she was going to be okay.
Just seeing that she is completely back to this beautiful young girl that's just full of life, and there's no handicap. And when we saw her come in, she was lifeless. And I think that the telemedicine service is a great deal to do with her success.
Honestly, I think there's no excuse for any hospital in our state not to have it, because we are here today doing great things with Annie and raising money for traumatic brain injury research in her honor and not in her memory, and I think that's because of telehealth.
So Dr. McElligott, we were just hearing about this family who was out in a rural area of South Carolina and needed emergency treatment for their daughter who was suffering from a brain hemorrhage. I'm wondering, this is something that's obviously becoming more and more regular with more of these hospitals closing in South Carolina. What's the typical situation that you guys are seeing down at MUSC when it comes to emergency care for people who are being life-flighted in, and how telemedicine plays a role in helping prepare your physicians in Charleston to receive these patients?
It's really amazing to see what type of streamlining and how much of, with an urgency, two different health systems can work when you're communicating well with telehealth. So, I think it actually starts the education before the encounter. When you have this partnership between two hospitals, it's not just that encounter. There's actually, when they set it up, when they talk about it, they educate on how to do best practices that you might only get at, say, the medical center at times, but you're extending expertise, you're extending how to work well together. Sometimes it begins even in the ambulance. Well, the ambulance team, the local emergency room team, and the specialist team and in the urban center might all be working together. So when something happens, in the way that we can sort of make it simple is say they know how to press the easy button, but they've also done all the things that we would do in Charleston. And then the team is fast. They get onto the video, they assess, they get all the data they need, everything that they need to do. And what happens upstream from that is the surgical teams get prepared quicker, the operating room gets repaired quicker, everything gets streamlined, and it starts with communication before the encounter occurs. But it has so much to do with streamlining how we work together. And it's been sort of one of the great joys of my career to see that happening, that two health systems will partner all around one patient and it goes smoothly.
So more communication, you're saying, coming from the field to the OR, to the doctors on the ground. I'm wondering, years ago when you had patients being life-flighted to MUSC, was that a different story when you didn't have as much information maybe coming from these people on the ground in the rural area? It was just maybe what they were telling you from the chopper itself?
Absolutely. Being able to visualize how a patient looks, especially a child, how they look and be able to respond and know how severe it is. In one way, sometimes you can look and see it's not that severe, and maybe you can save some costs. You don't always need a helicopter. Mm-hmm. Sometimes you really do, and sometimes you need the operating room to get prepared. But also, being able to relate labs, being able to, for the surgeons to see imaging like CT scans of the child's brain. Mm-hmm. We can transmit those now. Before, so telehealth is video, but it's other things as well. So now they've seen the scans, they've seen how the child looks, mm-hmm. They know exactly what they need to do, and they can be fast.
And switching from emergency care to maybe more maybe chronic disease management, I'm wondering for people who have diabetes or high blood pressure, is there a way for them to use telehealth to be able to see their doctor and not maybe have to go to the doctor all the time for these regular checkups too?
Absolutely. So some of the power of telehealth is that collaboration. Some of the power of it is being quicker to get a patient's access to care that they need. But also another piece of the power is what we can do over time. So a lot of times the traditional model is very sort of physician-centric. Like you come to me and I get 15 minutes with you and I discover your history and I predict your future. And I'm really good at it, but that's what we do. Mm-hmm. With telehealth, I could ask, well, how's your blood sugar tomorrow? What's your blood pressure a week from now? And what do I do with that information as it changes over time? How can I change the medication over time? And so when we monitor patients, and sometimes we counsel with video, but sometimes it's using your blood sugar device that beams the blood sugar level to a cloud that we can review. Mm-hmm. So the real power is what can we do now by keeping in touch with you over time rather than being physician-centric, it's patient-centric.
Mm-hmm. And then really quickly, Kathy, before we go to another segment, I want to ask you about how this helps with costs too when we look at telehealth. And you're not going to the doctor every time, but you're still consulting with the doctor at the same time and getting the same kind of advice in some situations. Is this helping patients save costs at the same time?
Tremendously. You bring up diabetes, and in a rural community, you can bring in the endo piece, you can bring in the podiatry piece. Unfortunately, a lot of the diabetes ends up in amputation, it ends up in renal disease failure, and if you can bring those specialists to that patient that can't travel, absolutely. Same thing in a school. If you can treat the child in the school and they don't have to end up in the emergency room, you have saved significant cost on that unnecessary ED visit.
And again, it just goes back to getting people educated to be able to use these services.
Education is a huge piece of it. It's probably the biggest thing that we do. The technology is not that difficult anymore. Finding providers that want to provide the service is not difficult, but the education of the consumers and the providers and the health professional is a huge component of what we do every day.
Gotcha. And the medical community are not the only that are advocates for telehealth. It has seen a great deal of support from leaders at the State House as well.
The type of health care you receive shouldn't be dependent upon where you're born. And so that's one of the key components of telehealth. And so what we need to do is we need to make sure that the rural areas are not left behind with voids of health care.
We are very blessed in South Carolina to have great specialists. Most of those specialists are located in your metropolitan areas. So the challenge is getting those specialists out into the communities, and telehealth provides that opportunity to utilize those resources.
So that's the reason and why we as a state made a conscious decision to invest in it, so that we can keep the rural areas just as vibrant as our more metropolitan areas.
So Kathy, I kind of want to talk a little bit about telepsychiatry. We've talked about these other aspects, but we're seeing it expand also into schools. And like we know, there's not enough mental health counselors in schools or across the state as it is. So I'm wondering what we see telepsychiatry, what role that's going to be playing going forward, not only in schools, but maybe in the community itself.
Well, as you can imagine, mental health is just an amazing topic. The funding over the years has been cut, and we have school shootings. There's lots of trauma in the schools at times. They lose a loved one, just their typical lifestyle. So providing telemental services in the schools is a huge benefit to the patients. In Bamberg, in our high school, MUSC provides a trauma-focused mental health program for kids that have experienced any kind of trauma. That could be from a car accident to the loss of a family member, and that has seen some great results. In Darlington County, which is in the PD region, the Department of Mental Health and MUSC and Care South, which is an FQHC, they are partnering to bring telemental services into that school district. Yesterday, as part of Telehealth Awareness Week, we did a regional telehealth symposium in Florence and sort of really tried to focus on some of the services in the area that some, say, Care South and McElligott can provide to the area. And we did a showcase on the Darlington schools. And the nurse practitioner, Gay Douglas, was there from the Department of Mental Health talking about, you know, if a child is physically sick or if they have a lot of stuff on their mind from a trauma that they've experienced, they can't learn. I mean, they can't focus on what the teacher's trying to teach in the class on math because they're stressed or they're anxious or they're depression. Depression is a huge issue. So telemental health is a tremendous benefit to our state, and the more that we can provide it in the schools and catch the kids at an early age, I think the better off we'll all be health-wise.
And Doctor, we were talking about how rural hospitals have been closing, but we've also been seeing a primary care physician shortage in South Carolina too. What are you seeing done at the state level to kind of help plug that gap? We talk about, you know, physicians' assistants, we talk about nurse practitioners. Sure. How does all that fit into what telehealth offers too?
Well, and I just want to make sure I start with the fact that, you know, it being Telehealth Awareness Week and the legislature being so supportive of everything we've done, how broad this is, you know, all the largest health systems in the state, Prisma, McLeod, and the community hospitals, Spartanburg, Anderson, all these communities in Georgetown, and then the Department of Mental Health and the practices at the level of federally qualified health centers and private practice in rural areas, they're all involved. So I think it's important to state it from that perspective. There's always been regulatory challenges to changing and innovating in healthcare, no matter what you do. And telehealth is by no means an exception. We've worked very closely with our licensing boards and our legislature over the past 5 or 6 years to codify the ability to do this and make sure we do it safely and well. And it's been a great partnership in our state. Most recently, we've solidified that nurse practitioners and physician assistants can do telehealth. And that's extremely important because telehealth opens up new access. But we really need our multidisciplinary team and all of our professionals practicing at the top of their license throughout the state to get to the care goals that we have for our state.
And when we talk about that legislation that's been passed most recently this year, dealing with physicians' assistants being able to do more responsibilities, have more responsibilities, I'm wondering, so that means that telehealth, as long as they're connected to a doctor, is my understanding, nearby, they can help offer additional services?
Well, what has been established is that they can do good care and that they can practice well, and they're supposed to have a collaborative relationship with the physician. Telehealth can enable that collaborative relationship. It can offer additional consultation, maybe between a physician and a physician's assistant, say, and it does allow them to be able to practice in their rural areas more, which is the important part. So yes, the language allows for that collaboration to be extended, and telehealth enables that.
And I know I want to stick with you, Doctor, really quick, because we talked earlier about telestroke, which, you know, we're talking about telepsychiatry, we're talking about all these different facets. But telestroke is something that's kind of interesting because I do think of, you know, say, for example, a loved one is suffering a stroke in rural South Carolina, they're not near a stroke center. How can telehealth help stabilize them or help them make sure that they're, you know, not fading as fast as they probably would if they had no connectivity at that point?
Certainly. Well, the management of stroke with telehealth now goes from prevention all the way to rehab. But I would say the part that telestroke has taught us is that these type of services can be brought to scale and can change even your statistics in a county. So now in our state, if you stroke, no matter where you are, you should go to the closest hospital. It used to be that you should go to the urban center or the biggest hospital nearby, and the ambulances knew that. Now they'll take you to the closest place, and you'll get expert stroke care right there. And so what happens is game changing. You know, they get treated quickly and appropriately and safely, and they get transported faster, just like the child we saw, but for the adult with stroke. What we are seeing now after years of doing this and doing it at scale, thousands of visits happening each year across the state, is that we are seeing that your chances of dying in a rural county by a stroke are dropping just because of telestroke. And so it's a wonderful thing to see, especially when you know that we're in the stroke belt and we have a lot of strokes. And so what it teaches us is that telehealth can be game-changing.
In 30 seconds, Kathy, what's the future of telehealth in South Carolina?
The future of telehealth is to increase access to care for all residents in South Carolina. Your zip code should not define the quality of care you receive and the quality of the life that you live. So it is our goal and our purpose to make sure that every resident, regardless of where they live, have access to high quality health care services. And I think telehealth can help with that process.
Well, thank you to Dr. McElligott and Mrs. Schwarting for joining us. And also check out the South Carolina Lead. It's a political podcast that can be found on your podcast app on any mobile device. Each week I recap the weekly political news with the reporters who cover it. From the Kennedy Greenhouse studio on the campus of the University of South Carolina, I'm Gavin Jackson.